gentlemen, perhaps if I start with you, Chris Coleman. There's actually a few Chris's here, so I'm gonna go Chris, Christian, and Chris Taffer. So Chris Coleman, let's set the scene. So what is the current medical skills gap in the physical or corporate security world, assuming there is one?
I think there definitely is one. From the perspective of training, from the perspective of delivering services, from the perspective of interacting with principals, and as a business that provides the services, I think there is a significant gap. I'll leave the medical advice to the medical professionals. From the operational perspective and the fundamentals, I would say that we need to go back to the fundamentals when we're training protective operations. I would frankly go back to the hard skills that would be provided by someone like Dr. Sidford, Paul Stewart, the medical professionals, Christian, and I would really spend time on applying what we all know as the golden rules of protection to the training and including medical scenarios. A couple of things that for me that come to mind are, the protectee must be protected from all threats, hazards, and embarrassment. Let's talk about, are we protecting them from themselves? They're making bad decisions. And we'll hear from our medical professionals about how we inform our protective operations folks about how to help them protect them from themselves. They're not going to want to go out. You're going to have to be that wisdom in the operation. That is that wise sage person saying, this is time to speak up and say, do not go out. Privacy's got to be protected. Pay attention to the HIPAA rules and other data privacy rules for individuals. Don't let them be embarrassed. Pay attention to the lifestyle. The lifestyle of our protectees does not necessarily feed directly into this pandemic environment. Pay attention to that. Maintain your professional and ethical standards. And I would say communication is probably the number one thing. You've got to communicate closely with the protectees. And that's something that a lot of our protective specialists are challenged with on a daily basis. We teach our protective specialists, you need to speak when spoken to and pay attention to being quiet, because that's the facilitation, the professionalism. When it matters to their safety and security, you've got to speak up. You've got to be that sage advice in this medical emergency environment. That's one of the gaps. Apply medical scenarios to the golden rules of protection.
No, that is sage advice. Paul, what do you think? What's the current medical skills gap? Obviously, one big skills gap is not having a massive bunch of ventilators and stuff like that. But Paul, what is the current skills gap?
I think largely that there's been such a huge focus on the trauma side of things, particularly, and understandably so, because that has been one of the significant threats. But I think within that means that people have maybe taken their eye off the ball. As Christian mentioned earlier, kind of, it's not sexy medicine looking at the kind of the medical scenarios, the medical conditions, and something like this, a pandemic, which is unseen, to an extent unavoidable until it's already too late, because once we know it's there, that ship's sailed. And also going back to what Chris is saying about the lifestyle of some protectees, if the client is very used to having essentially no borders, no challenges in traveling anywhere in the globe, actually they can be the hardest people to try and pin down and self-isolate. So whilst it may seem easy, because you may have expansive estates, numerous locations to choose from, I think actually that could be the challenge. And if your own team medical capability is restricted to what they've done on FREC 3 course, for example, or first person on scene, it's very trauma orientated, and with no offence intended, that's largely trauma by numbers, see this, do this. There isn't so much wider thought or breadth of understanding to then tackle something like this. The media, the lack of ventilators, it is a problem, but it's probably something that is people are more fearful of than their individual circumstances will dictate. The vast majority of people still will not end up on a ventilator. So some reassurance is as important as having the capability to deal with something should it happen, I think.
Okay, moving across to Christopher. What about you? Are you more optimistic? Is there a skills gap, or what might it be in this current crisis?
Well, in this current crisis, I think similar to probably the last 10 years of being in this business, the number one factor has always been medical intelligence. It's either in anticipation of where you're going or what you're doing or what your principal or client is going to be expecting. And then how do you advise them in various situations? And Christian, by the way, made a bunch of wonderful points this morning about when things go wrong, they go really wrong. And being prepared and training it as much as you can. But without a doubt, it is still, advice is key. And the more you're prepared, the better you're capable of advising your client. And the key fact still is, protecting yourselves first as your own patient first is the priority. And that still is, after 10 years, that's easily the number one message for today is the very skills you learn are the ones you get to share and impart on your principal or your client.
No, indeed. And it's good because on this panel we've got paramedic, we've got a non-medic, we've got an MD, and we have an embedded medic. So it's good to have a cross section. Christian, I know we've talked, or you've talked about people getting excited, evasive driving courses or tactical courses. Is this a skills gap that they're now going to have to finally pay attention to?
Well, I think so the skills are pretty much the same, even though that a lot of nations do things differently and teams do differently, and depending on what training you take. But as Paul said, if it's related to trauma, in the end, it's all the same because there's only so many ways to treat this kind of stuff. I think the biggest skill gap that we have here, and something that we are seeing when we are traveling abroad, is the fact that there is no international standard which allows me to do my job worldwide. I can be qualified any way which I like. I can travel to a country where I am not even allowed to put an NPA in somebody's nose or advise them on any medication, or give them ibuprofen if I want to, because that country doesn't allow. So as a medic, I can be traveling with my kit and I've got my medication on me, which I would have to leave at home. And I think it's not really a skills gap. I think it's more a legislative gap that keeps us away from doing a lot of good work to people, because I can have international students come to my training, and then I tell them, okay, you know what, in this case, you do this and this and this, and then they will come back, well, I am not allowed to do that in my country. So we can give them the skills, and I think that everybody basically gets the same skills. I mean, ever since the attacks, the NAEMT, TECC, and TCCC is now the standard in Belgium, which is great, but most of the invasive techniques are simply not allowed under Belgian law. So we're giving them the skills, which they will never use here because they aren't allowed to. And then in the end, a paramedic from Belgium will go out and work in a remote country where he has to do these skills that he saw in training, but never could actually practice in real life. And I think the real gap is going to be there, that we teach everybody the same, but then not everybody can actually use it and be good with it. Like, TCCC teaches the Crike. Fantastic. And, I realize there's a doctor speaking, but, I have done the Crike so many times in training. Ask me to do it underneath a car today. I think the guy is going to die because I'm just not confident enough, because in Belgium, we are not allowed to do it on the ambulance. So I think the biggest gap is the fact that there's no international legislation allowing, like, what can we do as a paramedic? What is a paramedic? It's different in every country.
Okay, well, in no favorite order, let me then just ask Paul, because I know Paul is, has a lot of opinions on what a paramedic could be or couldn't be. How can we develop the competency in this sphere, especially in preventing someone contracting a contagion? If we don't have a standard across the board, and if we don't all agree what a paramedic is, I suppose we all agree what an MD is, but how on earth are we going to get contagion prevention into our strategy?
I think arguably, actually, that's one of the things that probably needs the least in terms of legislation. It's very simple. If you like, keeping clean, avoiding one another doesn't need any kind of medical qualification. That's really just down to common sense. I think in terms of skills gap, yes, there is a challenge. There are certain things and certain medications you can or can't take to different countries, but usually decent advanced work will get that covered. So, for example, we've discussed with the FDA, various European countries, as long as you're working within a team and have physician letters, etc., you normally can take the medications you need into that country for the purposes that you're doing. However, yeah, going back to the contagion point, I think really what a paramedic is something that we probably need to do some more work on as well. A paramedic in the UK is not the same as a paramedic in Australia, is not the same as a paramedic in America. But to set the standard at the highest level, whichever someone's opinion of that may be, then brings with it huge training resources, financial resources, and countries that simply cannot afford necessarily that infrastructure and training, do you then deprive them of having a paramedic to their interpretation compared to in other countries? It's difficult.
Well, what about you, Christopher? How would we embed contagion medical planning into our risk assessment?
Well, unfortunately, we're actually struggling with that within the very hospitals that it's supposed to be a standard, because the first issue is obviously some intelligence, hand washing and so on, but then it has to do with the proper equipment. And it can be as simple as, face masks or sanitizer or gowns and so on, depending upon what you're doing and where you are. And there's a shortage, a terrible shortage and misplanning on so many people's part that we're struggling through that in the hospitals. So out in the field is if you have that equipment, which I'll get to in a discussion a little bit later, there's a number of things you can do on how to be safe. And there are places like Singapore and Hong Kong that have demonstrated, even in places in Wuhan, that demonstrated some very good infection control with hand washing and face masks and the right idea between seeing patients. We are unfortunately also struggling with a really lack of leadership on what our goals are for as a population. One end of the country you can't leave your home, and the other end of the country is out on the beaches. So that's probably our biggest challenge. I think everybody on the talk here is pretty focused on their own responsibility in this issue and their own hand washing and social distancing. So that's actually probably the biggest part or biggest solution.
It's a tricky one when you're actually in it, stepping out and looking at what you might do when you haven't finished what you are doing. I guess that's a tough one. But Chris, from a strategy perspective, we hear stories. A lot of people looking after ultra high net worth individuals went off to buy ventilators, paid for it, was told they'd get a particular delivery date, and then poof, they don't exist. Too little, too late. So how can we develop a business continuity strategy? With this in mind, a contagion. How are we going to improve our medical requirement inside it?
Which Chris?
Sorry, Chris Coleman.
Oh, sorry. Okay.
I think Chris, if I just interject quickly,
please.
It's a very common request. I can't tell you how many times I've been asked for ventilators and intensive cares and so on. And it's a very common misconception that the ventilator is the answer, and it's really not the answer. And in your world, it's like buying a gun. It's the intelligence behind it. It's the medically trained. It's all the support staff. And a ventilator is essentially useless without the right people around. So go ahead, Chris. Just throw that in.
No, I mean, just to maybe touch on a couple things. As this sort of swirls around, I think there are high net worth families that are asking for very unique support. I think those are going to come down to very difficult ethical questions right there on the spot, both for providers as well as the families, as well as executive protection professionals. Those are all going to be very difficult ethical challenges. Whether or not they're available, that will be simple supply and demand and what's out there. I think we're seeing this already in New York and in Seattle and some other areas of the United States. Clearly, we've seen it already in Italy. We've seen it in South Korea, China. But the challenges here, I think, are going to come down to leadership, communication. They're going to come down to making tough decisions. We've taken the stance on our end is do the right thing during the crisis. That's really what we have to boil this down to. Yes, we want leaders to lead. Yes, we want individuals to do what they do best. But when it comes down to it, when this is all over, and it will blow over, and we will work through it, you need to be able to look back and say, I did the right thing. It's going to be important for us to have a retrospective here that matters, not only just, what did you do in that time of crisis for the protectee, but what decision did you make? Not only for the family, what about the domestic staff inside the house? What are we talking about for the pilots that are traveling with a family? What are we talking about for the EP people that are going out and being asked to buy food? They're exposing themselves into environments and then bringing that contagion potentially back into the residence. So there's issues around ventilators, there's issues around equipment. Those are what they are. We have to make good decisions. But if we lead, we set good examples, and make hard decisions knowing that when it's all over, we can live with those decisions. That will go a long way, I think, to help us get through this. If I may touch on briefly this competency piece and the risk assessment element, I would add that you've got to integrate medical and health risk into your holistic risk assessment on the front end. Whether you are running the corporate security team or you are a vendor that is providing the bulk of the services, we need to insist on a holistic assessment. It's not all about terrorism. It's not all about crime. It's not all about IT and cyber. You've got to look at things holistically. And that's where I was talking about the basic fundamentals of training. You've got to apply the basic fundamentals inside your assessment as well. I don't know how many clients that have called me in the last 2 weeks and saying, come out and do a continuity of operations plan for us, or come out and build our plan for us. I'm like, I'm sorry, mostly too late. And now we have travel restrictions across the country and it gets more and more difficult. We can advise them virtually, but in most cases it is too late. For those that are individually resilient, for those families that are prepared, and for those companies and those countries that are ready, that's where this is going to come down to: individual resilience, family readiness, and company preparedness and country preparedness.
Mm. And I like what you said there. People are going to ask, "What did you do? How did you act?"
Absolutely.
We all see opportunism happening all the time, and I think those people might not realize people are watching.
Yes.
Well, let's imagine the lockdown doesn't continue too long, and let's imagine we gain some sort of normality. It might be a new normality. Christopher Sifu, do you think we're suddenly going to see a big demand, not just with that old "should we have a paramedic inside our team" debate, a big demand for more medical staff? Like we would want, if a principal had a heart condition and we took him to Central African Republic, we'd want some nice medical things on standby. Maybe we want the same preparation if we went to New York or London next. Is that going to be a next big thing, Christopher?
Well, I mean, like Chris mentioned, we've seen a huge jump in the last 3 or 4 weeks of either new clients or former clients who are sort of understanding the need for some type of medical intelligence backup wherever they are. I mean, we all cover clients who really live in many different countries and states and so on, and the medical system is not capable of caring for them from many different locations. It's hard enough getting decent care in one facility. So as a facilitator of where to go and how to get information, how to make decisions in those various locations, like the medical decision-making in Manhattan is very different than in Cape Town. So we've seen a big increase in the number of people that are understanding that that is one of the great resources or luxuries that I think everybody on the panel is carrying: medical intelligence and capability. And that's a great skill set and security skill set to have in the world that's going to come out of the other side of this.
Well, I like that, and everyone uses all sort of threat intelligence services, and medical intelligence service is something they might not have thought. A question from the audience, Carl Persons, and I think maybe Christopher, you're best suited to this. What's the best advice for those security teams operating in and around a principal who is quarantined?
I'll come back to this a little bit in the talk. I think I'm on in about an hour with some of these, but I think the number one issue is consider everybody sick. Everybody around you have to consider is possibly contagious, because as we'll get to, the virus sheds at least a day or two before you develop symptoms. And that's the big challenge, is that people are underestimating the people who look well and considering that they couldn't possibly have the illness. So if you're looking after someone who is sick or isn't sick, you still have to go through the same idea. And like I said, in a number of studies, good hand washing, incredibly conscientious about the surfaces you touch, about the people, as Chris mentioned and Christian mentioned, who go in and out of that principal's house. You have to consider them all as a medical risk. And even now, in certain procedures that are performed in the ER, they're now assigning people just to help advise you on to what surfaces you've touched and how do you take off the protective garb. And so you have to go through the same ideas that there are barriers in the security world to security information, and the same in the medical. And now you have to sort of warp into having both. Everybody is a medical risk, and everybody, how do you assess them? And in this case, there'll be things, and I'll come back to this a little bit, but you know, do you do a medical history on everybody who comes in? Yes. Have you been sick? Have you had a fever? If so, you can't come in the building. Do you start screening and getting a forehead thermometer? Yeah, it's a good idea. Do you do it twice a day? Yes. Do you document? Yes. I mean, these are the same for the people coming in, and the same for the staff that you're working with, and the same for yourselves. We all have to assume that we've been exposed, and how are we meticulously careful about protecting ourselves as well as the patients.
Okay, fantastic. Well, no, thanks, Carl, for interjecting with that question. Christian Zerkovitz. So I remember we had this debate, should we embed a paramedic, or should we just use the skills that we've apparently all been taught? Is this game over for that debate now? Or do you think we're still going to be confused about what medical skills or whether or not we should use them?
I think that the debate is not over, and I am not 100% sure that that this crisis is going to help with the technical medics or simply the medics within a close protection team, simply because, well, basically, you know, and I'm going to be very honest. If somebody asks me, okay, you're a medic, you're a paramedic, whatever, you're a doctor, so what are you going to do? Because I think it's really important to also understand, if you look at the question, how do I operate around a principal that's quarantined? Well, the thing is that the whole threat aspect changes with the fact that it's not only your principal that's quarantined, it's the entire world that's quarantined. So all of a sudden, everything gets a different outlook. The whole threat risks, where are they coming from, who are they coming from, changes, because the world doesn't operate like this anymore. I was talking to our chief of police of Brussels the other day, who told me, well, crime rates are going down. Domestic violence is going up. And like, okay, well, yeah, it totally makes sense. Because, well, you know, people running around in the street with a television now all of a sudden are not hiding behind a million people in the street. They are in plain sight. So if we look at, is this going to change the debate, and does everybody all of a sudden want a medic in the team? I don't think so, because there's not a whole lot that a medic can do about this, unless we prove to our principals and to the teams that yes, we can, because as most of the panelists have already said, we can look at it from a different perspective, and we can look at it from a perspective of, I mean, if a medic tells me you should wash your hand, or just a security guard or a close protection operative tells me, then I will tend to believe the medic more. So I think we should not try to play the, well, I'm a paramedic, so I know what to do about COVID. No, I'm a paramedic that has been washing his hands his whole life because I've been dealing with diseases that I didn't want to get. So I think we should just take ourselves back to the level that we are actually at, follow the guidelines that have been put out there by people that actually know what we're talking about, and try to understand those from our perspective as a medical professional, and then translate that into the world of somebody that has no idea and that's getting bombarded by all kinds of information about this coming from space aliens all the way to, well, this is nothing. So giving sound advice to our clients with the knowledge that we have, and educated advice, that might change it to something where now clients might say, oh, you know what, you were actually really handy during this case because you gave me advice that put me at ease. This being said, we have to be really careful with what we're going to be saying, because it needs to be founded. And as Chris Coleman said, we have to be able to live with that. If 2 weeks ago I advised my client, oh man, don't worry about coughing, it's normal, everybody coughs in winter, and 2 weeks later he dies because it actually was a COVID cough, I'm not going to be really proud of myself. So I think it does make sense for us as advisors and people that they will be looking at to educate ourselves. We have a medical professional on our team. He's an emergency physician in Belgium. He is on our team. We pay him, but we pay him for this. When we run out of ideas, I can call him and I can ask him, dude, what are we doing? And as a team, we believe in what he says because, well, that's the reason we chose him. So yeah, as long as you know, Chris Coleman was absolutely right about what he said. As long as I can live with what I say and I know it's an educated decision, let's go for it. And that's what we stand by.
Okay, fantastic. Well, we've got just a few minutes left. And so what I'd like to do is incorporate our last question into essentially your advice for everybody. And if I start with Paul, and I'll preface this with you because I know you do a lot of training. Do you think everyone's going to rush out and in this era of home learning, go and get some sort of tactical medic training when maybe there's something wider they're needing? And so our question to sort of pep up our audience and make us feel a bit more optimistic about what we're going to do. How should we prepare to protect principals, especially in this contagion environment moving forward when we're allowed to? And I guess try and steer some of our audience away from what you consider to be bad training. Paul.
Well, in terms of whether it's bad training, that's perhaps not the way I'd term it, but relevance of training. So there's never going to be any harm in using these opportunities to refresh one's knowledge, to go out and do any available courses if they're available online. But remember, a lot of the skill set is practical hands-on, so there is a limit to what can be achieved remotely, understandably. Just kind of touching back on Christian's point there, what I would say in terms of having paramedic, doctor, whoever you're going to have on your team, everyone, yes, has an upper limit as to what they can do. It's not about a paramedic telling you to wash your hands versus a doctor or a normal medic. It's offsetting the need at which you need to look for that more advanced care. So once a medic reaches, like an embedded medic, reaches their ceiling, the paramedic can assess the chest, can look at symptom management, and can delay or offset the time at which it then potentially needs to move up to a doctor or critical care. So I think that there are definitely benefits to have there. Just to go back on that point. Training-wise, I think that QualSafe and a number of awarding bodies are rapidly looking to see how they can facilitate online learning.
That's also good, Dan.
Particularly at the moment as well, which is going to be an issue for people in confinement for long periods of time. But I would say choose something that's going to be relevant. Don't neglect the medical in favour of just the trauma, and seek people on your team who already have that knowledge and peer review, peer support and peer learning.
Okay, fantastic. So going backwards, Christopher Sidford, your advice, and I want to bundle in some questions which I think are useful. When do we look to the, how do we prevent false information coming to our clients and get proper medical intelligence? And what are we going to do to protect them going forward? Christopher Sidford.
Well, I'll just say we're struggling that with in our own government. How do we get misinformation out of there? I think there are certain groups that in each of our worlds that we refer to. In this case, I think I would refer to the CDC or the World Health Organization as my sort of starting foundation. And in some of the discussions that Chris Coleman and I have had with their teams and so on, if you're dealing with organizations or principals and so on, I think you need some foundation of a reliable organization like either of those. And each of your countries, you may have one that you particularly like. There are certain infectious disease daily outputs that I like to refer to because they have a different perspective. But one or two or three resources as a foundation. And then if I have to make a comment to a client or a patient about a certain issue that we disagree on, I'll quote who I'm referencing, why I'm referring to the CDC or the World Health, because these are experts who do nothing but but learn and practice and investigate the very illnesses we're trying to deal with. So I always look for at least a couple of good international, and there are so many in Europe and so on. So whichever ones you prefer, but I would incorporate it, whether it's your operating plans or your advice to clients. I would be, I use those myself.
Okay, well that's good advice. And I'm trying to collate some of these questions as we go through. Christian Zerkovitz, your advice going forward, and I'd like to embed Joel Bennett's question. Does embedding a team medic potentially reduce the need for outside intervention? What do you think, Christian? Is that a good way to go forward and protect principles after all this is finished?
Well, to be quite honest, I am a big fan of embedding a medic with as high as a skill as we can into any team for several reasons. First of all, yes, you can limit the ins and outs towards your client. You can limit the numbers of movements if your medic is allowed to do a lot of the good medical stuff. On the other hand, I do believe that the entire team should have a type of medical training. And I'm going to be very honest again. I didn't see the need for this myself in my younger career. And I think a lot of young professionals don't see this need because they have not had the opportunity to witness what happens when you don't have somebody who's medically trained and medically skilled. Even if we're just talking about, you know, having a principal who is 75 years old and has some kind of heart condition, and now we're waiting for an ambulance, and now you have a team that doesn't know how, you know, is this ambulance, is it going to just come onto the property? Is somebody going to stop him? Who is this ambulance? So it brings a whole lot of stuff. If you have a medical team, what we usually have within our teams, we have the full kit and the full gear, and we have all our own stuff. It is definitely a benefit, and it's going to help your client, and not just with all the sexy stuff, but simply with all the little stuff, and also in preventing a lot of stuff. This was already mentioned this morning. If I see the lifestyle is not correct for my client and he's putting himself into danger, yes, speak up. Yes, talk about it. I have actually had clients that, why do you get up at 5 o'clock in the morning to go jog? Well, okay, it's because, first of all, I hate jogging, quite honestly, but because, you know, we try to keep in shape, but also just because it's better for me to be in good shape. And why, you know, would you like to join? And I've actually had principals said, well, you know what, while I'm with you guys, why not? I will also come to the gym. Fantastic. And some people will look at it from oh, that's pretty cool. Let me show him how tough I am because I'm in the close protection industry. Or I can see, okay, you know what? We know that he has this and this type of problem. We can help him with this. Because a medic, you simply look at stuff differently. At least since I started doing medicine, I changed my view on a lot of things, and I look at things differently. And you know, I look at a knife differently when somebody picks it up in the kitchen, and it's the same as when you become a father. I'm not a father. I used to have a dog who died, but that's as far as I came to being a dad. But I'm sure that when you become a father, all of a sudden somebody, you know, walking around with a hot kettle of water is going to be different than when you didn't have children running around. And that's the same thing with medical skills. As soon as you have medical skills, everything changes. Armor in a vehicle changes. People getting out of armored vehicles to go to the contact changes, because as a medic you go, oh man, did you know that the only thing between you and the bullet was that, and what that bullet is going to do to you? So yes, I think there's it's better to have a good medic on your team.
Okay, and Chris Coleman, I just want to clump together two questions, one from Ed Elinan and one from Martin Scott. Martin asks about, you know, how can you suddenly bring more team members in to augment your operations, especially if you discover some of them need to self-isolate. So that's an operational question. And then Ed asks about what point you draw the line between liability and protecting future clients, because obviously the buck really always stops with them, but you're perhaps liable. So two operational questions to give people advice for going forward.
Okay, just to make sure I have those right. So the first one was how to bring more operators into the operation when people start to feel ill or need to self-isolate. I think that was the first question. So I'll just start maybe with what we've done. We've broadened awareness amongst the entire team. We brought Dr. Sidford in, Black Bag, advised the team. We passed all that knowledge into the estate manager and to all the domestic state staff. So that knowledge has now been spread, and we expect everyone to operate with the same sort of level of protections. So, and we're also on our protection teams, we're spreading our operators as well. So we're geographically dispersing our team around the perimeter. We're still maintaining, control of the site. We are limiting movements. We are social distancing inside our command posts and among our other environments. And as people drop out, we will probably start to switch to rotations of bodies. So shift 1 comes in, shift 2 and 3 stay home for a week, and then we'll rotate out in a typical continuity of operations type manner. So we're limiting the exposure of those that come in. We'll have to go to that at some point. We're not there yet. I would have already had trusted contractors lined up to come in to fill gaps if you need to. But I would love to be drawing down on manpower that has to be exposed right now. Hold them back if you can, depending on the threat level and what you're doing to protect your folks. I think that's one big thing. On the liability for future clients, I think, make sure I want to understand that question. What we've done is we actually took 20% of our largest team and we made them all EMTs. So we invested early. So we have EMTs, that's a large percentage for any protection team, but 20% of our largest team is all trained as EMTs. So we invested early. So I think where you go with protection of liability is to invest early in training, get people certified, make sure that they're operating under the right kinds of guidance, and go down that path. The insurance world is going to be turned upside down after this. I can't imagine it's going to be business as usual after this. So I'm not an insurance specialist. I'm a big fan of risk assessments on the front end and managing risk in a smart way. But pandemic is no longer going to be maybe we'll see it again in 100 years. I think this could be the first of several waves. We need to start paying attention and managing liability by being prepared. Prepared means being trained, having the right resources on the front end, and assessing it correctly from the start.
Fantastic. Well, we're out of time. We're slightly over, but it's okay. We'll keep everything rolling. Please, everyone, give our wonderful panel a round of applause. I guess you could do that in the chat function. Everyone's tremendously grateful for your help and input.